Morning, good afternoon, good evening, wherever you are, and welcome to this webinar on the basics of rabies with the collaboration of WHO, UNICEF, Gavi, Mission Rabies, the Global Alliance for Rabies Control, and TechNet. We'd be happy to know who's with us today, so feel free to introduce yourselves in the chat box and tell us your name and where you're from, for example. You can also use the chat box if you need technical support. I'll do my best to help you. If you have any questions during the presentation, please use the Q&A box. It's a feature that is available at the bottom of your Zoom window. You can ask your questions at any time during the presentations. Our panelists will answer them in writing, and if we have the time, during the Q&A session after the presentations. Finally, the session is recorded as per usual, and we'll share with you next week the links to the video as well as the slides by email. Since we have a lot of panelists and a packed presentation today, I'll share a link in the chat so you can read more about our panelists. I hope you'll enjoy this session, and I'll give the floor to Niklas.
Thank you very much, Alex. Please confirm that you can hear me.
Loud and clear.
Loud and clear. Thank you very much. So very welcome to this webinar titled Rabies Elimination, the Basics. And the webinar is divided into 3 sessions. The first one will cover epidemiology of rabies. It will cover the importance of dog vaccination and the support that the Gavi Alliance provides to countries that are eligible for that kind of support. Session 2 will talk about working together under the One Health umbrella and how to influence community and family behavior, social behavior change for the control of rabies. And the third session will be about the soon upcoming World Rabies Day on the 28th of September. Without more ado, I will now hand over to Bernadette Abela, who will give the first presentation on rabies, the basics.
Good afternoon, everybody. And in 10 minutes, I'm going to try to whet your appetite to see how you can be involved to combat this fatal disease. At the end, you will receive a whole slew of resources that you can go to refer to if you want more. Second slide, please. So just a quick cover on rabies. Most of the of rabies cases in humans come from dogs. So if we get the dog rabies under control, we will stop human rabies, and we have tools to stop the transmission cycle of rabies. We have vaccines in dogs and other animals. We've got a very efficient and safe vaccines for humans as well. We still have more than 55,000 deaths around the world, most of them in children. So we really need to be doing more to stop this horrible disease, because we know that rabies is a fatal disease. Once you start showing symptoms, that is your death sentence. So we need to prevent rather than cure, because there is no cure. And we have the tools to do that. One of the main tools is learn how to avoid being bitten in the first place. You can avoid even rabid dog bites. But also, when we work on rabies, it is an indicator of reaching the people who are the most disadvantaged of the society. These are the poor people who do not have access to good health services. But through working on rabies, we are also building capacity in the health systems, be it surveillance, be it diagnosis, be it management. And of course, we would be implementing One Health. That's working with other sectors to do the best job we can through our different priority setting. So we've set a goal 2030. It's going to be challenging to reach it, but this goal has brought us as a community together to see where we can work together and how to reach a goal of no more human deaths around the world. Next slide, please. So actually, children are the ones most affected, as I mentioned. And why? They play with animals. They sometimes behave in noisy or run and are more at higher risk of being bitten. They often have severe bites in the neck and the head, so it makes the virus have an easy path to the brain. And often the children are afraid of telling their parents that they have been bitten, and so they do not reach the care that they need. So we need to be targeting children, the parents, teachers, the community, so that we can prevent rabies, not only in children, but in the community in general. Next slide, please. And so, as I said, we need to work in a collaborative approach. One sector, the health sector, cannot do it on its own. We cannot overcome rabies alone just from the health sector. We need the animal health sector and we need the community. So we need to be building the timely care, scaling up dog vaccination campaigns, and building the knowledge and the awareness and the demand from communities that are affected. Next slide, please. So I've just mentioned One Health. One Health is an approach that brings the sectors together to get the best outcome from interventions. If you look at the slide, and I'm pointing to the red line, if we do nothing more than what we are doing about rabies right now, deaths in humans and in animals will increase. However, we put in post-exposure prophylaxis, which is what we do in humans after a bite to stop the virus getting to the brain. It's like a race of the immune system to stop the virus from getting to the brain. Then we will reduce human deaths very, very quickly, but never reach zero. If we put in dog vaccination, we reach zero very quickly. We stop transmission and get rid of the disease in the communities. Next slide. So we have built a coalition of actors, United Against Rabies platform. I would invite you to go to the platform. It started off with FAO, with WOA and WHO. We now have Gavi and UNICEF, many, many ministries of health, ministries of agriculture, public sector, private sector, academia, the CSOs. So it's a place where we can all come together, share our learnings, share our tools, and work together to a common goal of reaching zero rabies deaths. Next slide, please. So just quickly about the disease itself, the virus is actually emitted out via the saliva, and that is why the bite is the most efficient way of getting the virus into the body. After the inoculation of the virus in the body through the bite, it travels through the muscle and taken up by the nerves until it reaches the brain. Once it's in the brain, there's a replication in the brain, and that's where we start to see the symptoms. Again, the virus in that being will be transmitted through the saliva. All mammals can get rabies. It's the dog that is the main host. Just to quickly say that human-to-human transmission is only documented in cases of transplantation or via the mucosal route. In labs, we have to be careful that the laboratory personnel are vaccinated against rabies and that they have protection against aerosol viruses. And also, we should be careful when handling raw meat. We should not be consuming dog meat or other animal meat that might have been coming from a rabid animal. But we have no documented transmission from milk, for example. Okay, two main forms of rabies. The one we would probably know from the textbook is furious. That's where you have aggressive behavior, hydrophobia. Those are the main things that come to mind. However, there's a paralytic form that's less visible, and it takes about 4 to 12 weeks till the first symptoms arrive. Once the symptoms arrive, you will die, and it takes about a week to 2 weeks until you decede, and there's very little you can do about it. WHO has looked at its position around post-exposure and pre-exposure prophylaxis. There's a lot of information in both the references I have put here. I would invite you to have a look. But mainly, what is really important is what type of exposure have you had? If it's a category 1, that means that you have no exposure, actually. It's when you pet an animal and afterwards you might think, oh, could it have been rabid? That's where you just wash your hands, wash the place which had contact with that animal, and that there's nothing else you need to do. In category 2 bites, those are scratches, almost invisible, where there's no deep wound. That's where we would only need wound washing and vaccine. Also, if you have had a previous course of vaccination against rabies, you are considered prepped, whether it was for post-exposure or PrEP. You're considered pre-exposed, having the pre-exposure coverage, and in that case, you never need immunoglobulins. Category 3 are severe exposures. Those are deep wounds, multiple wounds in innervated areas, or mucosal contact directly with the virus. That's where you need the wound washing, you need vaccine, and in this case, immunoglobulins are also recommended. Next slide, please. WHO also looked at ways to save cost and doses on this vaccine so that we can reach more people at a lower cost. So we are also trying to scale up that countries align with intradermal administration of the vaccine. And this is just as the immune response of the body is equivalent to that provided in intramuscular. Next slide, please. I will not go into a lot of details. All the schedules are actually valid, but WHO has come up with a shortened schedule of 0, 3, 7 in 2 intradermal sites. And this is good because it increases compliance and it decreases costs. So this is the schedule we are trying to scale up, also with the help of Gavi as they start to roll out the investment of rabies. As I said, all other schedules are valid. And if you have been previously vaccinated, it is a even shortened schedule. And in this case, for example, you only need 1 site ID and on 2 days, 0 and 3. When we talk about immunoglobulins, this is a very expensive product, often not available. Only about 2% of the African people who have been exposed actually ever see immunoglobulins. But what is really important is to know that vaccinating quickly after the bite, immediately after the bite, will give us an opportunity to have the immune response being generated by the body. Immunoglobulins are passive immunization. They're sort of neutralizing the virus at the site of the bite. And we have had to find a way to prioritize the use of RIG if it is available, so that the most severe cases receive this product, while the others would not be able to receive it. So again, there's more about this in our documentation. Next slide, please. A lot of people ask about pre-exposure prophylaxis and why doesn't the whole birth cohort receive rabies vaccines? Well, actually, you always need post-exposure prophylaxis, even if you have had a full course of rabies vaccination as pre-exposure. So it really only removes the need for immunoglobulins. And so when you do the maths and the effort needed for this, WHO does not recommend it as a birth cohort vaccination program. But we do recommend it for individuals working either in laboratories or doing the vaccination programs, for example, or people living in very remote areas or travelers in remote areas. Again, here we've reduced the schedule length, so it's only on day 0 and 7, and that gives you enough protection. But you still need post-exposure if you are bitten or exposed to virus on this. And as this whole webinar will show, we need more than just vaccines, and we need the community to engage with us. We need a community to know what they need to do if they have people in their community what they need to do if they are exposed, how can they prevent bites. Bites will never go away, even if rabies goes away. So we really need to be working at a community level, meaning we are a community as an international, but I'm talking village, asking, getting them to help design programs, but also increasing their voice for demand of services for dog vaccination, post-exposure prophylaxis, and other services. So we need them. We need to engage with them. Next slide. Here are a list of resources if you would like to know more. The first one is a comprehensive online training. It is all about rabies, touching everything between communication, human, dog vaccination. And so I would invite you to go there. I thank you for your attention. And if you have any questions, we'll try to cover them as soon as in the chat.
Thank you very much, Bernadette. There are textbooks about rabies, and they are big ones, real door stoppers, I can tell you. And you got the essential from Bernadette in 15 minutes. To be grateful. Now we are going to hear about the importance of turning off the tap, of stopping dogs infecting humans with rabies and dog vaccination. So over to Fred Law.
Okay, awesome. Thank you very much. I am trying.
You want to share?
Yes, please. Yes.
Yes.
I was
okay,
just
sorry.
trying to share.
I'll stop my sharing. You can share now.
Perfect. Great. Thank you. Thank you very, very much. So I have the task to beat Bernadette's time as well, trying to catch up and give you another quick overview of the importance of dog vaccination and why it's critical, really, in just about 10 minutes. So forgive me if I'm running a little bit every now and then. So my name is Dr. Frederick Lohr. I work for an organization called Worldwide Veterinary Service. And through our Mission Rabies project, we are working with stakeholders around the world to reach that 2030 goal. So let's quickly dive in. As you can see, the vast majority of the world actually is still, or a large part of the world is actually still rabies endemic. And even though some regions like Latin America have made tremendous strides towards eliminating the disease, even there we still have some pockets. And we really, really want to attack these areas to get rid of the disease and reach that 2030 goal. But initially, let me take you back in time a little bit to these little creatures, bats. And the rabies virus is really part of the lyssavirus family and thought to originate and co-evolve in bats and mammals over millions of years. And it's really unique in its susceptibility of species. So it doesn't just impact bats, but it eventually also impacted wildlife and impacts livestock and, of course, domestic animals and people. And this is really what we want to look at today at dogs. That's really the main species crucial for what we want to achieve, because 99% of all human cases are actually transmitted through dog bites. So let's have a look at basically the life cycle of the disease from the point of exposure all the way through to the death of the host. So from the exposure, let's say this dog gets bitten by another dog, we really have to live with a very long exposure period, really depending on the bite site. Because the virus travels alongside the nerves into the central nervous system, where it then causes that encephalitis, and the animal itself becomes infectious and really dangerous to people in this case. But to give you a bit of a real life example, so this is an example from Goa, where one of our teams were called to this house, and there one girl rescued a dog a few days earlier, a few weeks earlier. And she took the dog in. It was a street dog. She took the dog in, cared for it, fed it. But one day our team were called because the dog started to behave funnily, and also it bit the girl. So as you can see, when our team arrived, the dog initially looked deceptively happy almost in this picture. But these are the wounds that we can see that it inflicted on the little girl that was really trying to help this animal. And this is really another stark reminder that rabies comes in many faces and doesn't necessarily just look like we know it in movies and pictures, like this snarling animal attacking people. But this turned out to be a rabid dog. right? So, and what you can see when we're placing an inanimate object, like for instance, a stick close to the cage, you see this non-directed aggression. And this is really what would injure the girl. And this is what rabies does to these animals. So this is, again, just really a very stark reminder that we always have to be vigilant and that we have to protect children and communities from this disease, because people care about dogs. Dogs are man's best friend, right? So we want to make sure that these animals are protected and that the communities are protected. With rabies, we do have the situation that the disease is invisible in the host animal for the majority of the time, really, but only becomes visible and dangerous then as well to the community for a very short amount of time. Luckily, rabies has a relatively low reproductive number of R0 of just about 1 to 2, which means that an infected animal, on average, infects 1 or 2 other individuals before the host then dies from the disease. So when we're looking at this from a sort of population level, you can see the infected animal enters the population, the virus incubates, and then the infection spreads slowly through the population, but then really picks up. So this is, again, this is very deceptive as well, because when you see human cases, that's often the tip of the iceberg, and the disease had to spread throughout the population, the canine population in that case first, before we actually even see human cases then. And this is really where one of our tools comes into play, and that's enhanced surveillance. Enhanced surveillance, for instance, through integrated bite case management, IBCM, is a community-based approach where we really identify these animals, and we can then remove them. We can follow up with potential bite victims, ensure they get their post-exposure prophylaxis, PEP, and also then stop that spread of the disease by the safe and humane removal of these animals from the population. That's one tool. But our most effective and our most cost-effective as well tool that we have is really mass dog vaccination. So when we're looking at the goal of human rabies elimination by 2030 through dog bites, that's really the #1 tool that we have to look at, because this is where the transmission comes from. And we know that mass dog vaccination is very effective, no matter what methodology you're looking at, whether that would be a static point clinic in the community where people can bring their dogs to get it vaccinated for free, whether that is going from door to door to vaccinate dogs in the community, or catch, vaccinate, release, where we have to catch free roaming dogs, stray dogs as well in the community, or even at looking at the newer tools like oral rabies vaccination that we now have in our toolbox. No matter which system or mixture thereof you look at, mass dog vaccination is really the cheapest way to eliminate the disease and protect people and animals. So if we're looking at these vaccinated individuals, again, if you're looking at a static population, again, let's say a rabid animal enters the community, it then starts infecting animals. And you can see how slowly these vaccinated dogs act as a sort of stopgap for the spread of the disease. But then again, we're not dealing with static populations, right? So mathematically calculated vaccination critical threshold is one thing, but real life is another. So if we would aim for 40% in our mass dog vaccination campaign, as you can see, over time, we're only covering really or exceeding that threshold for a very short amount of time. And for the majority of the time, we're actually below. And that enables the virus to continue to circulate, and we can't get on top of the situation. And this is really why we're shooting for our 70% vaccination coverage. Because if we're reaching that or exceeding that, as you can see, for the majority of the time, we do stay above our critical threshold. And of course, the 70% figure is variable to a degree as well. I mean, if you have a very high population turnover through loads of disease, accidents, lots of puppies being born, dogs dying from old age, that always dilutes our population. So the higher the population turnover, the higher you should also shoot for your coverage. But on average, with 70%, we have evidence that that is a robust figure to aim at, to eliminate the disease from the dog population over time, and therefore also protect people against the disease. To give you another sort of real life example as well, where this happened at a large scale. admittedly not dogs, but foxes. But in Europe, over the last 40 years, there's been tremendous progress in battling wildlife rabies through oral rabies vaccination, fox rabies in this case. So what you can see here is red are rabies cases in wildlife, and the blue areas are the areas that are targeted for vaccination. And now, if we're looking at this over time, you can see how the disease is being driven further and further east through very targeted vaccination. You can see the adjustment of the vaccination area based on the cases. Until we reached 2006, and you can see here in central Germany, we still have a couple cases. Those are the last ones really here in Central Europe. And you can see them disappearing. And the important part here is we are actually vaccinating in that area even after those last cases have been detected for a couple of years. And this is really to make sure that we are protecting the area, that we're not having any sort of resurgence. Because when we're turning back time a little bit, and we're actually looking here at northern Italy, for instance, you can see how over time the disease came back from Croatia, but through targeted vaccination and continuous vaccination, most importantly, we were able to fight the disease further back, and now Western and Central Europe are rabies free. But of course, every program faces operational challenges, whether that would be activity tracking on a sort of like national scale. There's often uncoordinated data collection between the different stakeholders and actors. We struggle with setting priorities right. What do we actually want to achieve with our program? And often due to all of these factors above, there is a lot of duplication happening, and the individual acquisition and allocation of resources through each individual actor and stakeholder actually, ignore synergies that could otherwise be used in a very effective way to tackle the disease. But luckily, nowadays, we have a whole host of tools, a full toolbox that we can pick and choose from to tackle all of these issues. And just to highlight a few would be the vaccination team management and how we can tackle that. So we have mobile technology and IT at our disposal nowadays that can look into the vaccination team management and assist program managers with this on both a local as well as a national scale. Like when we're looking at an area that we want to vaccinate, we have loads of different vaccination teams targeting different strata of the dog population, for instance, like owned dogs with a door-to-door and stray dogs with a catch, vaccinate, release team, for instance. But what often happens is when we have these large teams spread over a larger area is, whilst this map would represent in orange 70% of that entire area being vaccinated, we often don't achieve our homogeneous coverage that we really want across the entire area. And we create these pockets where the virus continues to circulate and then can ultimately break out into the wider population again. And that often happens, again, in very difficult terrain with people who don't know necessarily the area. So what technology allows you to do nowadays is you can break any area up in, for instance, vaccination zones, and really use that to target specific areas with vaccination teams and get them to where they're needed and cover those areas thoroughly, really putting together this sort of carpet of different vaccination areas. And the teams can also, irrespective of that, collect loads of data in the field that can feed back in near real time to program managers, which again, in turn, makes programs more effective and efficient and cost effective ultimately as well. So mobile technology, a great tool to get your program under control. Similarly, it's often a big question like priority setting and where do we even start, right? And this is where risk mapping comes in. So the US CDC, as part of the International Rabies Task Force, which is a partnership between Mission Rabies, the US CDC, and MSD Animal Health, has developed something that we call the STARC, and that's the Settlement Type and Road Connectivity model. And what we can do with this model is we can create risk maps. Like, for instance, this one, where we can identify zones of high risk, of high transmission, and that are also contiguous zones that we have to tackle as a whole, in particular, if we want to eliminate the disease from those areas. And what this does as well is it gives us a starting point. This can be done from publicly available data, and it really helps us to allocate resources where they're required most. So this is really a resource allocation tool as well. And this is a help to get started in programs. So where can our limited resources that we have available have the biggest impact for the program, for the communities? All of these tools and then some more you can find, of course, on the United Against Rabies website. So when you go to the resources section there, you can see the UAR toolbox, and all the tools have been developed by UAR stakeholders and have been peer reviewed and are used all around the world. So if you want to access those, you can scan that QR code or go on that link. And then, of course, we at the International Rabies Task Force at Mission Rabies, we are also very happy to assist with anything, whether that is the risk modeling or, for instance, through the application that I've shown you before as well. So always feel free to reach out to us. We're very happy to assist you with this. And these tools are used all around the world as well by governments and local stakeholders. So with that, I hope I stuck to the time. Sorry if I was running a little bit here, but yeah, if you have any questions,
very
I'm
well,
here.
Fred.
Here's the
Thank
email.
you so much.
That's it.
And if you stop sharing, I will get back to share my screen, see if I can manage to do that. And you should now see a lovely dog with some kind of cover on its
At
ears.
the moment, I don't see it
That
yet.
right?
But let's see. Yes, there we go. Now,
Good.
yeah.
Yeah. So thank you very much. So this is a really important point, that the vaccination of dogs reduces the risk of people being exposed to rabies. Obviously, not all rabies transmission is from dogs to people, but a very large proportion, about 99%. So if 99 of 100 infected humans are infected by dogs, it is logical to start by reducing rabies in dogs, and dogs live very closely with people and engage with people. When someone is exposed to rabies, whether it's a dog that you suspect or know has rabies because it's died, or exposed to any other animal that may have rabies, it is really important to for that exposed person to be vaccinated with what we call post-exposure prophylactic rabies vaccination, which is an unusual vaccine because it's taken after you have actually been infected with the virus in this case, and it still protects you from the disease developing. And this is where the Gavi alliance comes in, because many countries, and particularly countries, low resource countries, low income countries, are challenged with having the PEP vaccine available at all times in the health system. And very often people will have to pay quite large sums of money to buy the vaccine themselves if and when they're exposed. And we are going to hear a bit more about this support from the Gavi Alliance to Gavi eligible countries, low income countries, to procure PEP rabies vaccine at better cost. From Simbarasha Mabaya. Let me see if I can now also move the slides. Yes, over to you, Simba.
Thank you. Thank you very much, Nicholas, and hello, everyone. So my name is Simba Mabaya. I work for Gavi. We increase access to vaccines, mainly for childhood vaccines, but we also getting more and more into vaccines for other age groups, including HPV and, of course, rabies that covers all age groups. Next slide. So I'm going to talk briefly about the support that Gavi provides for rabies post-exposure prophylaxis vaccines for Gavi-eligible countries. So I'm not going to have only 5 minutes, so I'm not going to talk about what is a Gavi-eligible country. Yeah, but I think we can. I can share a link which shows which countries are eligible and which ones are not in the chat. So this is the background to the support that Gavi provides, with the decision being made first in December 2018 to include the rabies vaccine for humans in the Gavi portfolio. But this was supposed to start in 2021, but could not start because of COVID-19 pandemic. And we only got a decision to unpause this in June 2023, and in July 2024, we officially launched the program, and we received the first applications in November, which were Cote d'Ivoire and Madagascar. And in July 2025, the Gavi board also reaffirmed their commitment to maintaining rabies support. So going to the next strategic period for Gavi of 2026 to 2030, rabies support is going to be maintained. Next slide. Next slide, Nicholas. Thanks. Yeah, so I'm not going to talk about the WHO recommendations. Bernadette has already spoken to that, but the support that Gavi provides, so those who are familiar with Gavi would know that ordinarily Gavi does not support a vaccine if a country has already introduced this vaccine with their own resources. But an exception was made for the rabies vaccine because we realized that most of the countries they already had some program in a way, but the program was really small because the cost of the vaccine was prohibitive. So any country, even if the country already has a rabies vaccine program with this, which they have introduced with their own resources, they're still eligible to apply for Gavi support. So this is kind of an incremental funding, but we do not provide support at the moment for pre-exposure prophylaxis and for the rabies immunoglobulin. We can only use pre-exposure prophylaxis if there is leftover vaccine after a vial has been opened for PEP and is at risk of being discarded. Currently, we've been providing vaccine ration grants and technical assistance for the application development, but this is going to change starting in 2026. So I'm going to talk about that. The details of that are still being worked out, but it's not going to be like that. So the vaccines are going to be procured, but the vaccine ration grants and technical assistance are still going to be procured, but not in the current form that they are in, like in a more holistic approach. I want to make an important point about co-financing on the previous slide, Nicholas, on co-financing, because I think this is quite key in terms of country decisions. So normally Gavi charges co-financing per dose of vaccine that is delivered. But for rabies, even if a country is going to use intradermal vaccination, where the dose is really zero, a fractional dose of the 1 ml vial, the co-financing is still being calculated per 1 ml vial, even if the country uses a fractional dose. So this is a very important point because it means that if a country uses intradermal vaccination, then the amount of vaccine that they are going to use is very low. So their number of 1 ml vials is going to be low compared to using intramuscular vaccination. And as a result, their co-financing obligation is much lower if they elect to use intradermal vaccination rather than using intramuscular vaccination. So it's something that we really need to keep at the back of our minds as we advocate for decisions within countries. Next slide. So I said on the previous slide that Gavi is going to change the way that applications are being conducted starting next year in 2026. I think most of us are aware that since the formation of Gavi in 2000, the number of vaccines that Gavi supports has increased. I think at the moment we provide vaccines for over 20 diseases. So with such a large choice for countries, there's need for countries to think about which vaccines that they need to introduce in their countries based on their epidemiology and based on their need. As I said previously, that every vaccine introduction is not entirely free to the country. The country has to pay co-financing, so there's a financial implication for countries to introduce vaccines even with Gavi support. So realizing that the number of vaccines that are available have become huge, the strategic advisory group of experts said in March of 2025 recommended that countries should consider a prioritization of all future new vaccine introductions, and that countries should be empowered to make these decisions for prioritization of their vaccines, and then to decide when they want to introduce which particular vaccines. And the process for this has to be systematic and country-led, which reflects the local context. So based on this understanding, so Gavi is going to revamp the application process. So at the moment, countries could come with a standalone application. So a country could just apply a rabies vaccine application or a full portfolio planning application, which includes all the other vaccines, and health system strengthening grants. But going into the future, we are going to use the country's national immunization strategic plan as the basis for the application, and then the country is going to make a comprehensive application that includes for the next 5 years all the vaccines that they want to introduce. They don't have to introduce them in the same year. They can then plan in the year that in 2026 we're going to do rabies, in 2027 hepatitis B, then in 2028 HPV, something like that. But we are encouraging countries to, based on their national immunization strategy, to think holistically about what they want to do in the next 5 years, and then they'll get funds which they are going to plan holistically for across all the introductions, all their HSS support, and all their TA needs. So the actual final details of how this is going to happen are still being worked out, and they're going to be published at the end of the year. But I think what we need to do as the rabies community now is to already to start acquaint ourselves with what is vaccine portfolio prioritization and optimization. WHO has been conducting some webinars to this, so we need to participate in those webinars, understand this process, participate in the country processes. When the country is revising their national immunization strategy, we have to be there. We have to ensure that rabies is there. We have to engage in all the discussions with the NITACs and all the other country level stakeholders, so that when the time for decisions is made, we are already there, we are already capacitated to engage, where our voice has already been involved. So we really need to start to think about doing that kind of groundwork now, as the decisions are going to be coming to the countries in the next few years. Next slide. So in those applications which we are going to be asking for next year, we're still going to ask countries to consider some of the things that we need to see in the applications for their rabies programs. This is just an extraction of them. This is really based on what we have been doing currently for the standalone applications. So we have a window that's closed on the 16th of September. That's the last window where we are going to accept standalone applications, and some of the considerations which are listed here are for the standalone applications, but they'll still be required in the comprehensive application. So we'll still need countries to think about transition to ID, because we're going to encourage intradermal vaccination. We're going to still encourage countries to think about where the rabies vaccine sits in their whole One Health approach, as well as their primary health care approach. We're going to ask people to think about data systems, think about integrated batch case management, and think about cross-border collaboration. So these are things that are still going to continue into the future among all the other requirements that are listed in the vaccine funding guidelines. Next slide, Nicholas. So lastly, I want to talk about estimation of vaccine requirements because this is a bit unique for the rabies vaccine compared to all the other vaccines that Gavi supports. So for all our other vaccines, the target population is the birth cohort, and then we just say, okay, we want to target 80% or 90% of the birth cohort. So that's pretty straightforward. But for rabies, because this is post-exposure, our target population is all the people who have been potentially exposed. However, we know that in almost all the countries, this data is not available. So people don't have data on the number of dog bites. They don't have data on the number of even the dog population. They don't have data on the need for PEP. So we are going to ask countries to use for the applications whatever data is available to them. It could be something from modeling, it could be something from research, it could be something from the current consumption data. So whatever you have, I think you can bring that in your application. It is going to be acceptable. We know that maybe as countries begin to use to introduce their vaccines, maybe in the next 3, 4, 5 years, then with the consumption data, the estimations for the vaccine requirements are going to become more and more accurate. I think that was my last slide. Thank you very much, and back to you, Nicholas.
Thank you very much, Simba. So I want to emphasize a few points that PEP vaccine is a very particular vaccine. First of all, because it's given to a small percentage, a small fraction of the population every year, not to every child who is born in a country. Also, that Gavi support to countries doesn't reflect whether the country have PEP vaccine in their health system or not from the start. And maybe most important, while introduction of new vaccines in countries, childhood vaccines, is a question on whether the country can continue to finance the co-financing obligations for childhood vaccines for many decades going forward. In making use of Gavi support for PEP vaccine is normally a saving for our country, because at the moment, most countries buy PEP vaccines for maybe $20, $25, $30 per vial. And if they are in the initial self-financing phase of Gavi support, they can buy it for $0.2, 20 cents per vial. And countries that are not eligible for Gavi support can still buy the WHO pre-qualified PEP vaccine from UNICEF, from UNICEF Supply Division, at $9 per dose. So for most countries, whether you're Gavi eligible or not, making use of Gavi support is a huge saving, can save you potentially hundreds of thousands of dollars per year. And for countries that are not Gavi eligible, you can still normally save quite a lot of money by procuring the good quality pre-qualified vaccine from Gavi Supply Division. That moves us on to the question and answer section after this, and I can see some of the questions in the Q&A, and I'm going to direct one of the questions, and that is from Kwada Asundova Chagwa, who says, how can WHO make available post-exposure prophylaxis and pre-exposure prophylaxis vaccine in low and middle income countries? We have partially answered that, but I would like to invite both Simba and Bernadette to talk about the PEP vaccine.
Yeah, I can start since I'm already on camera. So yes, so WHO is really part of the Gavi Alliance, and as an alliance, I think we are providing this rabies vaccine, post-exposure prophylaxis at lower cost, as not a much lower cost actually, as Nicholas has said. So I think this is kind of the effort that we are doing together with WHO, but also WHO is also his other efforts that they are conducting in terms of TA and other areas. So maybe Bernadette, you can comment on that.
Can you please repeat the question, Nicholas? Because there was a lot in there.
Yes, so the question is from Kwada, and he's asking, how can WHO make available post-exposure prophylaxis and pre-exposure prophylaxis vaccine in low and middle-income countries?
So as I said, WHO is working closely with Gavi to roll out in eligible countries. In general, unless there is a request by the countries for some emergency supply, in general, WHO does not procure vaccines. However, countries can procure their own vaccine either by UNICEF, as Nicholas just mentioned, or via WHO's catalog. But of course, working through Gavi does not only just provide the actual vaccine in a vial, it provides much more around that in order to build a program within the health system. So I would encourage countries to be thinking of the whole program, perhaps not doing everything at once, but at least thinking of their strategy and then rolling it out progressively. And vaccines are just one component of the vaccination program. I don't want to take up too much time. I've given you the justification why not PrEP and PEP. Economically, that is what currently our vaccines show, is it's just not viable to go out as a bird cohort vaccine. I hope I've answered the question. I'm happy to respond.
Thank you very much, Bernadette. I'm going to go back to this procurement of PEP vaccine from UNICEF. What we help countries to procure is the WHO pre-qualified PEP vaccine, which means that we can assure it is of good quality and we negotiate good prices with the suppliers. And that's why this vaccine is sold at $9 per vial to countries that are not Gavi eligible, and for as little as co-financing of 20 cents per vial for countries that take up the Gavi support for PEP vaccine. The volumes we help to procure for countries are actually very small at the moment. Over the last 10 years, we have not helped to procure more than around less than 80,000 vials per year, which is, to me, strange because there are huge savings for countries to make use of this procurement modality. So I would like to encourage anyone who works in a country and is thinking about how to ensure availability of PEP vaccine in your health system to contact your UNICEF country office and find out how to procure PEP vaccine. Now, also in the Q&A, there are a couple of questions about new methods for diagnosing rabies. I don't know if it's in animals or in humans, but I would like to ask Bernadette maybe to answer those in writing because I think this is quite complicated. But the principle in most countries is that you vaccinate someone who you think may have been exposed to rabies. If it's a dog, it's possible to observe the animal and see if it dies, and you will know whether it's rabies or not. If it's a wild animal, that is usually impossible. Let me see what other questions we have. There's a question from Edita about who is responsible for making the decision whether to vaccinate a human or not. And I think that's an interesting question because sometimes I think in many low-income countries, it's actually quite difficult for a health worker who cares for someone who has been bitten by a dog to organize the vaccination with PEP vaccine. So how is that done? Who makes the decision? And where do you get the PEP vaccine from? Over.
Okay, I can give it a start and then we can continue. So WHO has now prepared a tool which is sort of a risk assessment to help the clinicians decide what is a category 1, category 2, category 3 bite, and was the dog high risk of having rabies? Was it vaccinated? Was it in its garden and had very little exposure to other animals? So that will help you do a risk assessment. So that is one tool. How do we get the PEP? Usually in many countries, it's still only available through the private sector and you buy it through the pharmacy. But what we are trying to do is to get the health system improved in order to have the workforce understanding what to do if a person comes in with a wound or an exposure to a dog bite that could be rabid. Looking at that the vaccines are in the system somewhere, perhaps not in every private public health clinic, but maybe at a district level or a little bit higher. So it's not only about the vaccine coming to the clinic. It's a much bigger job. We need surveillance to understand where these vaccines need to go. So I'm not sure I've covered the whole question, but I'll punt it over to Simba. Happy to take any questions in the chat, and especially if we're running out of time.
Bernadette and Simba, I'm sorry, I'm going to interrupt you because we need to move on. But I think there is a question in the chat from someone, I forgot the name now, someone in Zambia who's pointing out that vaccination of dogs is not just a financial barrier, it's also a barrier of distance, and that many people don't have access to veterinarians that can vaccinate their dogs. And this transfers us to the next session, which is about community mobilization, and how do you get communities to vaccinate your dogs? What are the incentives? What are the facilitations? And how do you change behavior so that the risk of being bitten by dogs is reduced? And I'm now handing over, oh, sorry. Yes. Now handing over to who is here from UNICEF? Is it Joanna or Q?
Yeah. Hi, Nicola.
Hello, welcome.
This is
You
Chihui
should have
here.
should have your first slide. Please go ahead.
Okay. Good morning, good afternoon, and good evening, everyone. My name is Chi Hui. I'm a schoolhouse consultant at UNICEF HQ, and I will be presenting UNICEF's approach to fighting rabies in schools and communities across sub-Saharan Africa. Next slide, please. Next up, yeah. So as we have heard from the earlier presentations, children are really at the center of the rabies challenge. Those are under 15 years old account for almost 40% of all cases, and that's due to a mix of behavioral, biological, and social factors. So on the behavior side, children love animals, they're curious, they often cannot recognize danger, and some kids may even be like afraid of telling their parents if they had any incident with a dog. So awareness is also very low, both around responsible dog care and around the importance of wound washing and vaccination after a bite. And biologically, children is a smaller size, puts them at greater risk for severe bites, especially to their upper body, the head, the face, and neck. And those under 10 years old are particularly vulnerable. And then there are also the broader circumstances. So many bites actually happen right at home and are considered unprovoked. So we also see incident spikes during school holidays, when children have no or less supervisions from parents and teachers. And during crises like drought, migration, or conflicts, or the risks exposure increase even further. So the impact goes far beyond just physical injuries. Rabies can leave children and family dealing with trauma, disability, disfigurement, and stigma. And that's exactly why understanding children's vulnerability is so critical when we think about prevention. Next slide, please. So our goal here at UNICEF is to help eliminate dog-mediated rabies in sub-Saharan Africa. We aim to do this by raising awareness and tackling misinformation, and by linking school health programs with rabies control through a One Health approach. So prevention starts where children learn. I think there will be a presentation right after this on One Health, so I won't go into details here. We also plan to work to strengthen knowledge and access to post-exposure vaccines, and to break down the stigma, social barriers that can delay treatment. And at the same time, we aim to support countries with applications to co-finance PEP vaccines. So all of these interventions connects back to UNICEF's broader health work, from vaccinations and NTD prevention to community health and stronger health systems. And with our global reach, we are able to link schools, communities, health systems to make rabies prevention more effective and sustainable. Next slide. So schools are one of the most powerful entry points for improving health. Over 90% of primary school age children, which is nearly 1 billion kids, are in classrooms every day, and few platforms can match this scale or regularity, which makes schools very uniquely suited to deliver consistent health information and services. And that's where the health promoting school framework comes in. So Health Promoting School, or HPS, is jointly supported by WHO, UNESCO, and UNICEF. It views schools as healthy environments for living, learning, and working. And it's not just a one-time project, but a continuous effort to create supportive environment, and to deliver structured health education and connect to services in the school settings. So by involving various stakeholders like teachers, parents, students, health providers, and community leaders, the HPS framework can turn schools into hubs for both learning and health interventions. So within this HPS framework, this can translate into three key advantages. The first one is reach. School constantly deliver prevention message at scale, and then empowerment. Students become advocates for healthy practice, reminding parents to vaccinate pets or influencing their peers and family members. And last one is sustainability, which once rabies education is integrated into school curriculum, it becomes part of school culture. So to further make this work, school must strengthen links with health systems. So bites can be reported very quickly and referrals to vaccination services are clear and straightforward. So teachers and staff also need training to provide accurate information and immediate wound care, and rabies should be integrated into broader health curriculum along with many other essential health topics in the school. And some other practical interventions might include things like providing engaging classes, like lessons in the classroom, or providing safer school grounds or partnerships with communities for initiatives like vaccination drives, etc. And we believe together all these actions can make school powerful allies in protecting children and communities. Next slide. Next slide, please. So building on the role of school, the other very important pillar of UNICEF's approach is social behavior change, SBC. If school gives us a basic structure to reach and deliver health messages, SBC is more about making sure those messages translate into real and lasting changes in how people think and act. So in other words, it's not just about teaching information to kids, it's about shifting behaviors and social norms so prevention actually happens. UNICEF has a very unique advantage here. We already have SBC staff in almost every African country, and many local governments have national SBC networks and community organizations we can work with, which makes things very sustainable and scalable. SBC is also highly collaborative. It brings together so many different voices from teachers and health workers to religious leaders, youth groups, and influencers, etc. And by using platforms that people already know and trust, whether it's local radio, TV channel, or WhatsApp groups, we can spread the prevention message widely and at a very relatively low cost. And most importantly, SBC isn't just about sending messages from the top down. It's more about real participation so that children and communities are not passive recipients. They're more like active partners in the programming. And in practice, SBC can take many forms, including youth-led activities in schools, digital campaigns, awareness programs, capacity building activities or events and webinars like what we are having today that bring people together to spotlight the rabies prevention issue. So to just very quickly recap and bring all the approaches together, UNICEF's integrated rabies strategy is built around three main pillars, which is partnership, SBC, and schools. So partnership aligns efforts with national One Health plans and ensures strong collaboration across sectors. SBC makes prevention sustainable, driving awareness and behavior change through communication and campaigns. And lastly, schools anchor rabies education in everyday learning, creating lasting impact at family and community level. So together, these three pillars can form a very comprehensive and sustainable framework that connects schools, communities, and health systems together. So making rabies prevention part of daily life. Thank you very much for listening, and over to my colleagues, Nicholas, Ida, and Surani, if there's anything you would like to add.
Thank you very much. I think we need to move on, and we're next going to have a presentation by Professor Bonfort, which will be without slides. That's really interesting. The teacher I once had about social and behavior change told me that change behavior is to make healthy choices, easy choices in the society. And I've tried to live by that. But now over to Professor Bonfort.
Yeah, I will just add on top of that, if you make choices, you have to think who pays and how we evaluate the impact. That is something very interesting. Thank you, Nicholas. Yes, I am going to just take a couple of minutes to talk about One Health approach in public health and why it's critical for rabies elimination. A lot have been said on rabies, on collaboration, on engagement, but I will just try for this couple of minutes to come back again on what is One Health approach, why One Health is important in rabies elimination, and how we can go forward on that, taking into account what have been said earlier. So from my perspective, or the perspective on which we are now engaging with stakeholders, One Health is a matter of gaining or losing something, maybe gaining health or losing health under different collaboration and coordination scenarios known as the two prisoners' dilemma on their choice to go for freedom, or their choice to have many years of prison. I think this theory has been developed a long time ago. We have two main questions here. Is first, what is lost when each sector work in silo, or what is gained when they collaborate? This is where the collaboration matters in the One Health approach, is to prove the collaboration and see how we can improve health. And as far as rabies is concerned, it's very important to consider this collaboration and see how we can save lives, not only working in the public health sector, but bringing the livestock sector into play. We know that each sector holds part of resources. And when I say resources, we have knowledge, we have information, we have finance. And it's very important to put together those resources in order to solve complex problems. And we have seen that rabies is still a very complex problem. So the One Health approach is an integrated transdisciplinarity approach that recognize the interconnectivity of human, animal, and environment health. It's also emphasized collaboration across various disciplines and sectors such as public health, veterinary science, environmental science, and also other key players like communities. This collaboration helps to achieve optimal health outcome for all, known as the added value. And I have seen that with the mass dog vaccination, is very important to highlight the importance in the elimination process. So One Health approach is rooted by different bodies of knowledge, and understanding that could help to target different health threats, not only zoonosis, but also diseases emerging between human, animal, and environment, like like rabies. And this can be done with joint efforts. And as such, controlling these health threats, including rabies, requires coordinated effort across multiple disciplines, sectors, and very importantly, communities. And when we talk about communities, we include policy makers, funders, and also the population. We should not forget that collaboration is not only between the three health sectors, but it also involves funders, policy, population, with the help of the social science. So why One Health is important in rabies elimination? We know that rabies involves complex interaction between domestic animal and a bit of wildlife and human. And rabies is by far the best case of One Health issue because of first its complexity, as rabies elimination cannot be handled by a single sector. It has been provided by the earlier speakers. Second, we have collaboration between sectors and communities because coordination is key during interventions. And third, we have this coordination which needs to be invited when we have collective action from different sectors. And this collective action can save lives and avoid unnecessary death. And we have seen that sometimes when the vet sector and the human sector are not collaborating without coordination, we have death from rabies. And the fourth point is that rabies goes beyond just interconnection and call for informed decision based on different aspects, especially the legal aspect, the policy aspect, and the funding aspect, which is also very, very important to consider. And the last point on that is pooling resources is also a component of One Health because we sometimes sectors have resources, and when pooled that together under the leadership of a legitimate institution or entities like the national program, we can avoid wasting resources due to poor planning, inaction, or inefficient funding use. So the challenge with rabies is that it's also involve complex interaction that need to be considered. So why One Health approach is essential? Because public awareness and education need to be considered. Mass dog vaccination campaign need to be brought. We know that with UNICEF, with Gavi program, the emphasis is on PEP, but we need to have program that also take into account the mass dog vaccination, as this is the most sustainable way of eliminating rabies. We have the integrated surveillance, which is very important, already mentioned, and the PEP aspect, the post-exposure prophylaxis, which also need a very good coordination between healthcare providers. And here we need new tools, and I just want to highlight that we have adapted the blockchain technology to improve communication and the vaccine stockpile management in order to increase the coverage and also reduce the unnecessary mortality. So what is the critical importance of rabies elimination? The elimination is achieved through consultation and multi-sectoral effort. And by combining all those aspects that we have just mentioned, we can break the transmission cycle. And One Health approach can also address broader issues such as wildlife reservoir, ecological change, urbanization, which can influence the rabies dynamic and the dog population dynamics. And sometimes we lack information on this dog population. So in conclusion, what I just want to say is that as we have seen, and with the current challenge we still have for the elimination, we should not consider rabies just as a public health problem alone or a technical problem. We have to consider the condition of inequalities, the weaker health system, including access to veterinary services that has been mentioned earlier, and the political decision, which can make a big shift. And current strategy might help in some area, but without fixing the root control and elimination failure causes, we will not be able to reach the goal. So finally, One Health approach should be a necessity and a sufficient condition for tackling rabies and other complex health threats. And it should really promote collaboration, efficient resource use, because when we have seen rabies, we have many resources allocated, many institutions involved, but still we don't have the elimination target. So a comprehensive understanding of the governance of the health system, the governance of rabies elimination problem, this understanding will help to move to elimination and safeguard public health as far as rabies is concerned. So this is what I wanted to say so far, and I'm open for question, and thank you for your attention.
Thank you very much, Professor Bonfort. And this is just to reiterate that rabies elimination is not just about putting a needle in the arm of a person or a needle under the skin of a dog. It's many more things. And we are going to hear now from Lusungo and Wolube about how to make dog vaccination attractive and available in Malawi. We are just about to start a recorded presentation from Lusungo. Please go ahead.
Hello, everyone. My name is Lusungu Nguruwe. I am the National Education Program Manager for Mission Rabies. I'll be giving a very short presentation on community mobilization, focusing on how Mission Rabies does its community engagement during rabies vaccination campaigns. But before that, some short statistics on Mission Rabies. Mission Rabies was established in 2013, and to date we have vaccinated over 5 million dogs, and we have delivered rabies lessons to over 11 million children. In 2012, one of Malawi's biggest referral hospitals, the Queen Elizabeth Central Hospital in Blantyre, gained international attention when it reported highest incident of child rabies. This is from a single institution. In response to that, we launched our initiative to eliminate canine transmitted rabies from Blantyre. So we started working in Blantyre and slowly expanded into surrounding districts. Today, we are covering 15 districts out of 28 in Malawi. We hope one day Malawi will be the first rabies-controlled country in sub-Saharan Africa. Our main focus as a charity has been developing models that can be cost-effectively scaled to save lives. Across sub-Saharan Africa, we currently work with government partners in Malawi, in Tanzania, in Uganda, Ghana, Mozambique, Sierra Leone, Zambia, Guinea, and Burundi. So, how is community mobilization done? When helping to persuade people to get their dog vaccinated, there are some key rules that we use when planning interventions. And some of these include keeping key messages very, very simple. And also, engagement is done at all levels. from as high as ministry level all the way down to the community level. At the same time, we do the engagement every day, repetitively, so that people are able to understand what we're saying. Also, we make sure that we help to build the relationship between animals, the dogs, and the human beings. People should know their dogs, the dogs should know them. And also, we learn, we adapt, and we repeat. So last year's vaccination campaigns, we drew lessons from there, and those lessons helped us to perfect this year's vaccination campaigns. This year's campaigns lessons will help to perfect next year's campaigns. So we learn, we adapt the lessons, and then we repeat the process. And we make sure that everything or every activity we do is value for money. Very, very important aspect. When encouraging people to bring forth their dogs for vaccination, the most powerful word in advertising our activities is free. Vaccination is free. What channels do we use to conduct our community sensitization? A number of them. One of them is using the traditional and civic authorities. We use local health promotion networks such as the village development committees, the community-based organizations. We use churches, radio adverts, we use radio magazines, radio dramas, posters, flyers, billboards, the PS system, that's public address announcements. These mostly used by our colleagues, our partners, the community-based organizations when they are delivering their messages every day during the campaigns. We use community theater, we use social media, especially in urban areas, and then we also use the short messages on the text messages, SMSs. So locally, children often are responsible for caring for dogs. This happens in many, many communities. These are children mostly below the age of 15, 16. And as a result, they have been a victim of rabies disease quite often. This prompted us to also be delivering rabies lessons in primary schools where this age group is found. So we do train school health and nutrition teachers in public primary schools. We give them the rabies training and we request them to deliver the lessons to their children. This is to raise rabies awareness amongst children. And generally, the message that is given to these teachers is about the seriousness of rabies disease, how to prevent a dog bite, how a child can prevent a dog bite, how a child can conduct first aid when they have a bite, and also to let them know that rabies is preventable. And they should also help encourage the communities to vaccinate their dogs. They should be able to know how to stay safe around dogs. And in that way, they would be able to prevent being bitten by their own dogs or by stray dogs. So data is very, very important at any level, in any project or any organization. In Mission Rabies 2, data is very important because it helps us to make decisions at different levels, locally as well as internationally. Here we collect data from pre-campaign meetings, clinic surveys that we have, post-vaccination surveys, focus group discussions, as well as the CAP survey, knowledge, attitude, and practices survey. We in Mission Rabies, we collect data using the WVS app, which is a very important tool for us. It helps, once the data is collected, it helps to better manage our campaigns. It also, the data that we collect also helps us to understand the community's relationships with their dogs, as well as to understand the myths misconceptions, or the different attitudes that they might have in the communities. These help us to better focus our activities. For example, in Malawi, we moved to fixed point clinics thanks to research conducted with the University of Edinburgh, which from post-vaccination service identified obstacles preventing people from bringing their dogs for vaccination, and as well as maximum distances they were willing to travel. And because of that, in 2018, we planned our campaign and clinic locations in Blantyre City based on the findings, completing the program in half the time and at a much lower cost, doubling the number of dogs vaccinated per day. So that's how important data can be. So we never stop. While the community mobilization highest intensity is during vaccination campaigns, our education teams will keep on working throughout the year, promoting our surveillance hotlines, delivering curriculum development and teacher training, educating first responders, and so on, just to keep on reminding people of the importance of rabies disease. So as we're going toward the end, we have a toolkit at rabiestaskforce.com. This toolkit aids delivery of our packages throughout the planning, implementation, and evaluation stages of our activities. And education is a key tool in global fight against rabies, and to that effect, we have WVS Academy, and this is basically a resource site with some modules in it. One of the modules, for example, is understanding rabies, and another one is education principles and teaching strategies, and then we also have got another one delivering a rabies prevention lesson. And finally, I would like to thank all our partners for the support. If anyone is looking for any technical support in terms of delivery of campaigns, we'd love to hear from you. We have our website on the slide. Thank you all for your attention.
Thank you very much, Lusungu. It is with dogs as it is with babies. They keep getting born, so we never stop vaccinating them. Now, I'm going to hand over to Juan Pablo, who is going to present a resource that UNICEF is making available for community mobilization through something called the Internet of Good Things. Over to you, Juan Pablo.
Perfect,
Nicholas.
Thank you so much. And thank you everyone for joining. I am Juan Pablo Arguello. I am the SPC digital specialist, specifically working on digital tools. And I'm going to present to you some content that we have created collaboratively in UNICEF. It is focused on IoT, which is a tool that we use to be able to provide this information for people with limited access to internet, with limited devices. But also the content is open for you to adapt it as needed as per the tools that you use, the ones that are more relevant for your country or for your context. So feel free to also look into the resources and then adapt them as needed. Nicholas, quick question. Do you want me to present the slide, or would you be able to do it?
I'll move them.
I can present them if needed, but I cannot see them right now.
Oh, you don't see them? Okay.
No, I cannot see them.
Okay, let me stop. Sorry.
No worries.
Sorry, it's my fault. My sharing has stopped. That's the reason.
I think it's loading now.
Yeah, it's coming.
Perfect. So yeah, the first thing that I wanted to mention, just to briefly introduce the Internet of the Good Things. There's an open source tool, which means that anyone can use it. The source code is available for anyone to adapt it based on their need. Unlike other digital tools, this one has been designed specifically to include, to integrate inclusiveness from the beginning. So it is data light, it is works on low-end devices, and also it has been designed to specifically engage with low literacy first-time internet users. Right now, it has been deployed in more than 27 regional country platforms. It supports over 30 languages, and it has been deployed in it has engaged over 45 million users since 2015. In addition to providing information, it also enables different kinds of community engagement, which you will see. But also, this could be an interesting tool if you're also seeking to engage communities and at the same time collect information. So now I'm going to move on to the next slide, which are introduce the main aspects of the product. So in the next slide, you're going to see that we have created content for specific audiences. These are adolescents and young people, parents and caregivers, primary school teachers and school personnel, and primary healthcare and community health workers. There has been a collaboration between different teams and the SBC team in UNICEF. The idea was to deploy and content that can be easily adjustable based on the specific needs of the country office, but also providing some key information and key resources that can be adapted as needed. Not only can the content itself, the text can be adapted, but also the images and the different visuals that we have included. They have been included both in PNG, but also in editable format, so that anyone who wants to use these resources for their own campaigns can also do it. If we go into the next slide, one of the key components that we have included into this way of creating content was first building it with a modular design, and the idea is that perhaps different countries have different needs, and some of them might focus on engaging with a specific audience. So you can pick and choose what you need from the resources. You can focus on community health workers, you can focus on teachers, you can focus on parents, depending on what you need. And each specific content has been adapted on a specific SBC approaches and outcomes that we want to achieve without a specific group, right? So for example, the objectives that we have with parents are different than the objectives that we have with children and youth, and also the same thing between educators and community health workers. So the level of complexity, the level of information provided, the guidance provided, and the way of engaging also different audiences is quite specific, because we have also included different behavioral insights, making sure that, for example, we use trusted messenger for each group. Each group has a different, let's say, persona that presents the information. Very simplified steps that increase complexity depending on the group that we're addressing. Also, we have a whole bunch of engagement opportunities for commitment making, quizzes to be able to test your knowledge and see and get reminders on what you may be missing or might be confusing concepts, and also on the framing and messaging, focusing more on like validating and leveraging those specific protection values that different groups may have, for example, children and parents, for example, in terms of protecting their children. And again, the content can be adapted per needed. You can just see, I'm going to share the links at the end of the presentation, but you can see how each specific section addresses different questions and different content for the different audiences that we're trying to engage. And then we have also, in the next slide, integrated some engagement and M&E tools. The idea was to also help us find ways of, in detailed engagement itself, begin to measure some of those SBC outcomes that we want to achieve, right? So not focus on the usual engagement indicators that we get in detailed tools, such as reach and engagement, but can we actually measure changes in awareness, in knowledge, and in willingness, for example, to take action? This is something that we have incorporated as part of the overall engagement process to ensure that we're also able to see change over time. And as mentioned before, we have also used different features. One of them is storytelling. For example, some of the questions and some of the information that we're sharing is scenario-based questions and conversational tone. We also have included emotional and collective responsibility appeals. We also specifically focus on promoting personal commitment through repeated calls to actions. There are some of the examples in which people can engage if they feel prepared, if they want to commit on taking a specific actions, and then ways of also seeing what they would do, for example, on the part of the right to see what they would do in different cases. And then all of the resources are available here. We'll be sharing the link. Again, the content can be adapted. Feel free to review the links, use it as you may need it. You can also directly promote the content in IoT Global. But what we do is that in those 27 countries that have IoT, we share that content with them so that they can adapt it based on their needs. But also, if you want to use any other tools, we're more than welcome to use that. And we will be happy to provide support on how to adapt this, for example, to a chatbot or any other kind of format that you think is relevant for your community. I know we have limited time, so that's all that I'm going to mention. But if you have any questions, please feel free to share it in the chat or to just raise your hands. Over to you, Nicholas. Thank you.
Thank you very much, Juan Pablo. I'm afraid we have to skip the questions and answers here because we're running short of time, and we have to give time to Kerensa as well to talk about the World Rabies Day. And I think you want to project your own slides, isn't it, Kerensa? So please, if you start sharing.
If possible. Thank you. I'm so sorry. I feel bad now that we're skipping questions and answers. I'll try to follow suit in Juan Pablo's presentation and talk very, very fast through these. So this is about a very positive time of the year for everyone. World Rabies Day is coming up, the 28th of September. And I'll just run through this year's theme and some opportunities for everyone to join in. So this is the first time in 19 years that the theme doesn't actually include the word rabies, which actually attests to how well established this brand now is. The theme you will see at the banner at the bottom is Act Now, You, Me, Community. So we wanted a sense of urgency. We wanted the individual to collective action and responsibility to be emphasized. So this is a selection, and this banner, as well as the logos and things, are all available on our website. In addition, you will see it does highlight the One Health approach. This is just a little bit about the design and what's hidden behind it, because it's a global issue, rabies. The grain texture, so the individuals and communities all coming together. The different colors for the continents and highlighting diversity, the bond and connection between people and animals in terms of the paw and the hand, even in a protective kind of posture, and of course representing a One Health approach. So available resources. As I mentioned, we have the World Rabies Day logo in a variety of languages. The theme assets, so we have the banners and we even have t-shirt designs that you can contact us for. We do have a World Rabies Day event planning manual to help you decide and organize and plan your events and activities around that day. And we also have the World Rabies Day themed social media toolkit, which, as you can see in the screenshot here, provides text, hashtags, and the visuals for you. So, in other resources, there are also radio scripts so that you're prepared for any interviews you may be giving. We have the GARC education platform that offers free online rabies courses. The Rabies Educator Certificate is a foundation course. Once you have completed that, all the other courses are open to you, but you have to please complete that one first. They're all self-paced online with downloadable PDFs, and you do receive a certificate at the end. We have modifiable posters to use for World Rabies Day, and we have, of course, a lot of other rabies awareness resources you can download and use freely. Some proposed activities that people can do is to hold a World Rabies Day event or activity. It can be something as small as a talk at a school or a coffee morning to international events and conferences. It really doesn't matter. Registering that World Rabies Day event or activity on the global map. I did share a link in the chat, and I will do so again for everyone. You can share the posts from the social media toolkit, which is minimal effort to everyone. And of course, you can learn more about rabies through our certified courses. Last but not least, open until the 14th of September. You can nominate someone for a World Rabies Day award. These awards are to highlight individuals, whether they work as part of an organization or not. So please, if you know someone who's doing work against rabies, do feel free to nominate them or yourselves. We have 4 categories. There is the education champion, veterinary clinic champion, vaccination champion, and animal welfare champion. Once we have all the nominations in, the shortlisted list will be available on World Rabies Day, and then public voting opens up until the end of October, with the awardees being announced on One Health Day, the 3rd of November. For any more information, please just drop us an email at support@rabiesalliance.org. We'd be really happy to help you with anything you're organizing, and I look forward to hearing from you. Thank you.
Thank you very much, Carenza.
Well, I hope I did it fast enough.
You did
Thank
it
you
very
so much.
well and fast and clear. And we have reached the end, and we are just 11 minutes over time. I would like to thank all of you who have connected and stayed on for such a long time. And I would like to thank all the panelists and the presenters for their engagement. And I hope you stay connected. The slides and the links to resources will be circulated to everyone who has registered for the webinar, and they will also be available on the TechNet 21 website, where there is also a chat around rabies and around World Rabies Day. And you have all the links that Carenza provided for the commemoration of World Rabies Day. By the way, can someone tell me why we are commemorating World Rabies Day on the 28th of September? There is a small reward for the first right answer. And with that, thank you very much for attending this session, and please share the links to the recordings when you get them in your networks. Thank you and goodbye. I can see that Nicole was first with the right answer. Congratulations, Nicole Corrado.